Medium-term planning framework is out from the NHS. This potentially is the delivery document looking at the 10-year plan. And in this episode, myself and Andy are going to review the document and explain how this applies and who this applies to in general practice and wider to help you understand what you probably need to do over the next few years. So let's get cracking as we tech enhance your primary care and learning. Hello, eGPlearners. Welcome to this episode. Myself and Andy are reviewing the medium-term planning framework, which came out just last week for the NHS. And it's a pretty interesting document, isn't it, Andy?
It is. So I enjoy it when we have a look at these policy documents on the channel. I think this is an interesting one because we've had the NHS 10-year plan, we've had a long-term plan, we've had a workforce plan. So this is a medium-term plan. And they say in the foreword that the idea behind this is to move away from short-termism. So that's why they've kind of filled that gap with a medium-term plan, I guess. It's going to be interesting to go through. It's always worth reflecting when we're looking at these documents who they're intended for, and it looks like this is really intended for an ICB audience primarily, and at the end there are some plans that need to be created and submitted, and it seems that that's really the ICBs that need to be doing that. But as ever, I think these things are kind of relevant for everyone, particularly people who work within ICBs or a place level or primary care network level, but even probably for individual sort of GP partners, maybe even GPs who have an interest in leadership. I mean, what's your thought about who this might be relevant for, Gandhi?
So agree. I think very much this is directed at ICBs, place-based partnerships, that kind of stuff, the higher levels of general practice and stuff, and whether that's going to be the new collaboratives that we're hearing about in the future, maybe. But I think there's absolute relevance. So if you're running a PCN, so PCN CD, etc., that kind of stuff, having an awareness of this. And if you're a partner, particularly if you're a partner of a larger partnership, I think there's absolutely aspects of this that come into play that looks at what potentially this whole neighbourhood working might start to look like as well. And if you're involved in some of those aspects, there's real understanding. And when this hit, this is the one that said about 90% of urgent care being seen in primary care, which we're going to cover in a bit more detail in this, because that was the one that caused a lot of contention for general practice in particular. So there is key relevance to understand what this document looks like, but it's not just around primary care. That's the key thing as well.
No, it's the whole NHS, but primary care is a big part of that. I guess as ever with these documents, best way to look at them is to pick them up, open them, have a look at the contents page, get a lot about the structure of the document and the content from that. Probably the most interesting part of these documents, I would say. So what are we getting here from this document? So we're getting some introduction, forward, setting the scene, and then 4 sections essentially. So 1, incentivizing delivery, creating the conditions to transform care. Section 2 will be around resetting the foundations for a new operating model. So there's information in there about new contracting arrangements, and there's some information about what they intend the different levels of the NHS to look like, from sort of DoH down to practice level and all the layers in between, and there are some changes there. Section 3, what have we got in section 3, Gandhi, just so people know what to expect?
So section 3 talks more about the operational aspects and what does that look like in terms of transformation and basically the doing. So it's a key aspect in that part. And then section 4 is next steps, isn't it, Andy?
Yeah, and who needs to do the plans and when they need to be submitted by. And as we said before, I think this will give everyone, even if you're not involved in creating those plans, an idea of what ICBs will need to be concentrating on and what the landscape's going to look like going forward. So relevance to everyone working in general practice, I would say.
Definitely.
So shall we just sort of dive in, really? I think as ever, what you're getting from this video is our reflections on this document and what speaks to us as GPs. I also have a role in the place-based partnership and sort of board of a GP federation, so there'll be things that jump out to me. And Gandhi, might be worth just reminding people the many hats that you wear, so people can understand why things might be jumping out at you.
Yeah, so I guess medical director of a GP partnership, also a PCN clinical director, and like most people, I'm involved in lots of various local aspects and things. But I think the forward kind of sets the tone and stuff of what the document looks like, and it's a good summary to look at. The interesting thing for me is who it's written by. So this document is being authored by Wes Streeting and Jim Mackey, who's the CEO, sorry, the chief executive of NHS England. So, you know, the two significant voices in current direction of healthcare have signed this off. So, you know, this is not a small document to be, you know, avoiding or not being aware of and things. So important to recognise that.
Yeah. So things that just jumped out at me from the forward. There's a lot in there, but they're saying, right, we don't want any more short-termism. We need medium or long-term plans. They talk about using this document to close the gap between the national centre and service level, which I think speaks to a little bit about maybe the removal of NHS England and the real shaping of ICBs there. And they're talking about a better connection between grassroots and central planning, I think, and they want a return of locally led ambition. So that just jumped out at me, which again speaks to grassroots, although we hear that a lot in these documents. And then they're talking about and this is really to supplement the 10-year health plan. So a lot of criticisms of the 10-year plan were, okay, sounds very aspirational, but how do we get there? So they're framing the document as something that provides a bit more detail in terms of the delivery. Those were the main things that really jumped out at me. I don't know if anything else jumped out at you with the forward, apart from who wrote it.
No, that's the main stuff, like you say. It does make reference repeatedly to the spending review and the funding that provides for this. So this is over the next 3 years, which is why I think the terms of this is very much for the next 3 years. So this goes from 2026 all the way to the end of 2029. So it is their in-government plan. That's the key thing. This is what they plan on doing before what looks like to be the next general election.
So yeah, so they sort of plan within this parliament, I guess, which is quite sort of honest, I guess, because they can only plan for as long as they're in power. So that's sort of sensible in many ways. So, and again, introduction, just things that jumped out. So you're right, they talk about SR25, sort of spending review 25, which already existed. And that was where 22 billion additional pounds were allocated towards the NHS. It was the biggest government part. It was the department that benefited the most out of all government departments from that spending review. And a few statements that sort of jumped out to me really were just acknowledging the size of that investment. That they tell a bit of a story arc in there. So they talk about, okay, we've allocated lots of additional money, but confidence within the service to deliver is at an all-time low, or was at that point. Confidence in staff and confidence from patients, and then they're saying, well, we've got an opportunity to develop on the 10-year plan to improve this. And actually people spoke to us about that plan with genuine optimism. It's probably a bit of a mixed bag really in terms of the response, but that's the kind of narrative arc that they're saying. And then they want to sort of reset the relationship between centre and service, which seems to be a theme in terms of how they're framing this. They acknowledge that some things have been done already. So ICB leaders have drafted the model ICB blueprint, which is something that we've covered before. They've redrawn the maps of ICBs. So locally, our ICB is now part of an ICB cluster with shared leadership. So that's Nottinghamshire, Derbyshire, and Lincolnshire. So there's been those changes already, and they talk about ICBs moving to strategic commissioning, which speaks to doing less, but doing the commissioning in a more strategic and sort of effective, impactful manner when you look at outputs such as sort of population health and so forth. So, and then they the other thing also they talk about, and again, I think some of the audience is sometimes people outside of health, and sometimes they have to justify their spending. So they talk about actually this health spending could be a macro level economic stimulus for new technologies, UK health, UK life sciences businesses, things like that. So they're sort of placing it within a national industrial policy sort of context, I think. But so these are the main bit in the introduction really is talking about some headline aspirations, and they divide that into elective cancer and diagnostics, urgent and emergency care, primary care, and mental health, essentially. Do you want to kind of go through some of these, Gandhi?
Well, I think so. We did cover this in our last live episode in terms of the summary of the introduction. So I think moving forward, what we're probably going to do, Andy, is go to the detail section. So this episode, we're focusing much more on the chapters themselves and the detail, and this comes back up anyway. So probably worth.
I'm getting carried away. Here. That's fine. So the 90% comes up later, does it? In section
Yes, it
3?
does. It comes up later. Don't worry, we'll get to that.
Because that's the thing that ruffled a lot of people's feathers and made it into pulse with this document. So, right. Okay, so let's go to section 1. And do you want to lead us through this, Gandhi?
Yes, section 1 talks about financial contacts and kind of what the existing system currently is. It definitely sets out this concept of that the funding allocations potentially may need to change, and very much that there needs to be longer term planning of the way that we use the finances. It basically brings this up multiple times. In that particular section, you can see, so it talks about better alignment to more robust delivery. It talks about fairer distribution of funding. So we've heard about the fact that the Cahill formula may be readjusted. It's definitely something that I know we've talked about on numerous occasions. That and for those who don't understand, Cahill formula is the adjustment that's played into general practice funding based off the GMS income to try and tailor it more to the local population the practice looks at. However, Cahill is massively out of date. We're talking it's 20 years old plus, and it doesn't take into account many of the determinants of actual health issues that have an impact on capacity, productivity, and all that other kind of stuff in general practice. So one of the things West Streeting has committed to is that there will be a review done of the Cahill formula. Now, whether that comes out to an actual change, we don't know. Big question is whether that's going to increase the funding provided to it, because if it's a zero sum review, then there's a question, there's going to be winners and losers, and chances are if you're in a more suburban, leafy, richer kind of area, then those practices are going to lose, and those practices in higher dependencies, health inequalities being a key challenge, they're likely to win. What does that mean for outcomes for patients? That's a really challenging part to do it, but we will probably cover that when the Cahill formula review comes out in more detail, don't you think, Andy?
Absolutely, yeah. And then I wonder if there's a way that they can kind of cheat and separate out existing from additional or optional funding. I think they might be able to fudge that in some way. Got thoughts. Anyway, let's carry on.
Yeah, they talk about some of the tools then that they plan on using, and also looking at capital spending as well. So one of the, I think, key recognitions that currently exist, that capital spending is a really fluctuant thing. So most capital spending has to be done in year, which doesn't quite work for a lot of places, because then you're kind of left with a scramble of people trying to spend resources so they've got it again for next year, and that doesn't really lead to effective spending. So potentially there's an aspect of changing that so that they can have a better way of doing that. They're also talking about bringing in a new UEC payment. Now, Andy knows this, and in our last episode, I mentioned this, that UEC, what does that actually mean? Because they don't, in any part of this document, actually explain the acronym UEC. However, it is a title in there. It's Urgent and Elective Care Payment.
Emergency, I believe.
Emergency, yeah, there you go. See, I still get it wrong because they don't explain it. So urgent and emergency care payment. So this potentially is looking at a payment model for people attending in different mechanisms to bring down the waiting lists, surgery aspects, urgent care potentially. And this may be where some of the 90% plays into play that we talked about earlier. I don't know. But they're looking at providing a different tariff for looking at how people attend from an urgent and emergency care perspective. It'd be interesting to see what that looks like. And Andy, I know you've been part of some of the boards that potentially look at some of this, haven't you?
I have, yeah. It's difficult. I mean, my experience has really been about just systems managing demand. So it'd be interesting to see how they can sort of contract to improve the management of that. I think I'm going to have to wait for the details here, Gandhi.
Yeah, absolutely. And it very much talks around, not just urgent care in the sense of people attending with coughs, colds, or acute illnesses. It also talks about day cases, outpatients. It's that whole aspect, and more importantly, make sure that people are seen in the right ways of getting it right first time, the grift principles and that kind of thing. So it basically commits that there's going to be a review of these processes and looking at how that's going to work. It then focuses on the page 10, I think it is, about how does that look like in terms of delivery. So there's a key recommendation here about delivery of 2% annual productivity ambition as a minimum. So it's whether they put ambition and then a minimum time amount that they have to do. So we want you to ambitious and try and reach this, but it's still a minimum criteria that you have to achieve. And
I guess maybe they want more, right? But
yeah,
the 2%.
Definitely.
The least they'll accept. Okay.
Yeah. Delivery to break-even financial position. Interesting that general practice continues to provide that anyway, but other parts of the system don't. and therefore that concept of moving towards that, which has been on almost every single plan for time immemorial, I think, and adherence to other criteria in terms of commissioners and that kind of thing. So, and potentially some deficit funding may be in place, but it needs to be reported on a regular basis. It then talks about productivity, so that's section 1.2. And this is the one that me and Andy had a little bit of a chat about beforehand, because it talks about the fact that hospital productivity grew from 2.7%, but that's still well below the total levels, are still below what happened in COVID. And despite the workforce growing and that kind of stuff, it doesn't mention primary care in this section at all. So I was a little aggrieved about this, to be honest. The fact that it focuses on the fact there's not been any productivity increase in secondary care, but it doesn't talk about the fact there's been huge productivity gains in general practice. I think this is a misstep, and I think it's a deliberate misstep, to be fair, for me. But that's my cynicism coming through. I don't know what you think, Andy.
Yeah, I think primary care is definitely part of it. Does it mean we're off the hook for productivity increases? Who knows? Probably not. Yeah, and I think it's interesting to think about productivity, isn't it? Because I think we kind of look at our appointments as something we're delivering more appointments. I think it depends on how they're going to measure what their measure of productivity is, which I guess is sort of output per worker at the very least. And if you measure that in appointments, then productivity in general practice has increased an awful lot over the last few years. But if you measure it in terms of sort of patient outcomes, then maybe not so much. So I think I don't know enough about how they're measuring the productivity, actually. It might be an interesting deeper dive to go into.
Absolutely.
Yeah, we're going to have to do more with the same number of people or fewer people. Fair enough.
And then there are definite themes that come through from this. So one, it focuses on terms of using technology to drive forward further productivity changes. And we're going to come back to some of that in a second. It then also talks about taking advantage of opportunities. So this is halfway down. Sorry, we're still on the page above. Apologies, Andy.
Apologies, Andy.
Yeah, that's okay. And supporting, the delivery through various different organisations. It does say that there's going to be more productivity measures that come into play. But the key thing is that a lot of this should be tried to be delivered at scale. And again, you're going to see that throughout the document that, at scale provision is where the aim is going towards. The next page is page 11, which is the last page of this particular section. It then sets out the two key things in summary, so that UEC transition to digitally first and clinically prioritize access. So really interesting. I mentioned this earlier. There's a driver throughout this document about technology being the driving force for this. So things like having triage-based systems built into access. And it doesn't just mean primary care. That's the key thing. It's not just talking about primary care here. This is talking about systems. It's talking about secondary care as well, community care as well. So I think we're going to see an increased use of triage as a mechanism to manage healthcare moving forward. And then also about booking aspects. So, currently general practice uses booking links in a lot of places to send to patients to sort out their appointments. I think there's going to be a key direction of travel that secondary care, community care are going to have to start doing similar as well, reading this particular thing, with a significant increase of same day or next day scheduled care. So moving towards very much shortism. I don't know what the right word is. Yeah, but yeah, that's the first part. And then I'll let Andy come in a second. And then the second part is that outpatient shift. So a digital first, patient-led model. So moving away from the standard, we're going to see you again in 3 months, 6 months as a part of a review for outpatients, moving very much more to patient-initiated follow-up. So the patients get to decide when they come back or initiate that follow-up. So that whole bigger concept of an open review potentially, rather than standardly, we're going to see you back in 3 months, standard, we're going to see you back in 6 months or a year and things, and having the mechanisms to particularly driven by technology to do that, and reducing the need for an outpatient fault model as we currently work with. That was my understanding of this section. Any thoughts, Andy?
Yeah, just a few reflections actually. So really like the idea of secondary care potentially using booking links, because we found that quite transformational really in the way that we manage appointments in general practice. Sending patients a link so they can view available appointments themselves, pick one that's convenient for them, that they're most likely to be able to attend. That sounds really, really welcome and a good idea, and possibly fairly simple to implement. I was also reflecting on like the productivity challenge, and obviously digital and technology is a way to drive productivity, but other things also improve productivity, such as training, for example, investing in in human capital and investing in other infrastructure, which is non-digital infrastructure, equipment, places to do things, things to help people do things better. And there are a few other, obviously, sort of traditional drivers of productivity, which I'm thinking not sort of mentioned directly there, I guess, Gandhi, but perhaps alluded to in the rest of the document, I suppose.
So we're going to move on. Apologies, we're already well over track for time-wise, and that's probably my fault. So Andy, let's see how well we can get through this in a timely way.
Yeah, so this is a big section and it's complicated. So I think I'm just going to pick out sort of statements that interested me as a GP and someone who works at kind of a system level as we go through. So this is resetting the foundations of a new operating model. So quite foundational, quite fundamental. So they talk about, so this was an interesting statement. So what they want to happen is that healthcare activity happens as locally as possible. So, and digital by default, which we talked about before. So in a patient's home, if possible, in a neighbourhood health centre where needed, or in a hospital if necessary. So that was interesting. And like, where's the GP practice, right? So is the GP practice the neighbourhood health centre? Just interesting use of language there, because neighbourhood is bigger than the GP practice. So I found that interesting as a GP, that layer of the system wasn't acknowledged there. So they talk about not punishing, that's not the word they use, but addressing failures and failing parts of the system. And they talk about rewarding success with greater freedom, potentially greater funding as well. So the next bit I think is really interesting. So they talk about the roles of the different layers of the system in terms of the different organizations that are there. So they talk about the centre, which must be the Department of Health and not NHS England, because that's going to be abolished. They set their role is to set like the outcomes and communicate the standards and to like build the national platforms that people use and provide air cover by removing barriers and challenges. They talk about regions and how many regions are there? Is there like 7? Like there's not.
I believe so. There's 6 or 7, I think. Yeah.
Yeah. So they talk about regions. So this is the leadership interface. Okay, and they have line of sight and responsibility for overseeing performance, financial delivery, workforce, quality, and responsible both for grip and for support. So grip is a new word for me. I'm not quite sure what that means. So I thought that was interesting. Do you know what grip means? I know what support is. It must have a strategic definition. I should have looked it up before. I just thought it was a really interesting word that speaks to kind of an action. Anyway, potentially a correction. I grip the lead of my dog when I'm correcting it where to go. Anyway, so ICBs, they become strategic commissioners. We've heard much more about that, really. ICBs are going to be doing less.
The GRIP stands for Getting Research into Practice.
Okay. Is that what they mean here? It's not capitalized. I'm just wondering what that means.
So the acronym means getting research into
but it's
it.
not capitalized. So you might be right. But I'm just noting it's not capitalized. And that would be quite a specific thing to put there, I think. But maybe you're right. So ICBs moving towards being strategic commissioners, providers. So and there's quite a rich landscape of different providers, but through a revitalized foundation trust process. So there's something about foundation trusts being key providers here, I think. So this level is responsible for collaboration, productivity, quality, earned freedoms for those who deliver, and proportionate intervention where standards slip. So they're intervening where standards slip and freedom where deliver. And then they talk about integrated health organisation contracts. So I think IHOs were mentioned in the 10-year plan, but everybody focused on MNPs and SNPs. But integrated health organisations are going to be key. And it's interesting that they're at a different level to maybe where the foundation trusts are. So that's interesting. And then they talk about frontline neighbourhood teams. So that's where the action happens. Established to support our communities, working with social care colleagues. They will deliver proactive support for people with frailty, long-term conditions. They will provide urgent and acute community services, rehabilitation and prevention, and support improved access to care, especially general practice. So we want improved access to general practice, enabled by digital tools and shared care records. So again, so the general practice is very much part of neighbourhood and not really acknowledged as a discrete entity in itself within this document. Interesting. Okay. So, and then I guess they just acknowledge that some things have already been sort of done to acknowledge, or so they acknowledge some documents that are already out there. So they acknowledge that the ICB blueprints are published. These are things that are, I think, exist or are coming. So model neighbourhood framework. So that's expected in November. Sorry, I think we've had the kind of model ICB blueprint earlier the year, but this is a different document. Model region and ICB blueprints coming out, some more official guidance about what they want them to look like and do, and model neighbourhood framework coming in November as well. So for those people working in neighbourhood space, that might shake things up, yet again in terms of stating expectations from the centre. A strategic commissioning framework will be shared in October. Hopefully that's already come out. I think it might have done actually. And there'll also be a foundation trust framework, as well as a system archetypes blueprint. So I don't fully understand what all of those documents are, but they will come to support the strategic direction which is set out within this document. Just a few of the things that jumped out, I guess. Responsibility for vaccination and screening will move to ICBs. So where does that currently sit, Gandhi? Is that it's with public health, right? Do they?
I believe so, yeah.
They obviously do screening, I think, within their budgets, and I think they fund vaccinations. So I'm not sure. Now, anyway, there we go. So there's 2.1, 2.2, 2.3. I think we'll probably just acknowledge broadly what is in these. So 2.1, unleashing local potential, foundational trust framework, integrated health organisations, and oversight of trust and system models. So they again talk about the documents that are coming out to provide guidance in that area. Really, I'm quite interested for the integrated health organisation element to be fleshed out, because they talk about that as something sort of separate to multi-neighbourhood providers, and I do that appears to be a layer sort of below trusts but above MNPs. I'm really interested to see how this works actually, whether actually an integrated health organisation holds multiple MNPs. Is that the intention? And I'm getting into speculation territory here, Gandhi. I do like to speculate. So 2.2, delivering neighbourhood health at pace. So priority for delivery of neighbourhood care needs to be a priority for every leader in the NHS, because it will create more space to do elective work, reduce waiting times, improve quality of care, and make headroom for leaders to focus on innovation. So it was that statement that it should be provide priority for every leader in the NHS. So just highlighting how important this neighbourhood health layer and concept will be. And then they talk about an immediate focus for implementing neighbourhood health on improving and tackling unwarranted variation in GP access for the whole population. So we can expect some further action on that. Any thoughts, Gandhi, about that? We don't know what they're alluding to directly, but
we don't. I think some of this probably lends to the 1st of October changes in terms of digital access, but then they're going to want to look at how can we smooth that over so that patients get a universal experience across practices. So I think that, like you said, there's more to come.
Yeah, I think we're getting a window into maybe some of the focus of SMP contracts and MNP contracts here, and that there might be something about tackling the variation in GP access. They also talk about reducing unnecessary non-elective admissions and bed stays for priority cohorts. So some areas that are beginning to say, look at frailty cohorts or people with multiple long-term conditions or specific long-term conditions. I think this speaks to the continuation of that work, and that the language of outcomes is definitely going to include non-elective admissions and avoidable admissions, and then enabling patients requiring planned care to receive specialist support closer to home. So that's going to be another priority for neighbourhoods. To expect, they will produce, so these are things to expect in support of this, a model neighbourhood framework. I think they've already said that's likely to come out in November, unless
the November time. So now, potentially, got 30 days.
National Neighbourhood Health Planning Framework, and model system archetypes, which will outline the 3 contract types. So this is where they talk about IHOs, MNPs, and SNP contracts. Then they talk about model neighbourhood health centre archetype as well. So I think that speaks to me about a bit of an estates sort of strategy, really, to talk about what neighbourhood health centres would look like. And they say together with new build solutions where appropriate. So I think they're talking about equipping health with places to do their neighbourhood health. I think it's probably worth then just acknowledging 2.3, so shifting from sickness to prevention. So many of these.
Before you do, Andy, so there was that section in terms of April 26, what ICBs and relevant NHS providers should do. I think worth identifying that first one in particular. So identify GP practice demanders above capacity to create a plan to help decompress and support and improve access and reduce. So they're going to be looking at this from April. And, there has been some commentary that since the 1st of October, there hasn't been a huge kind of, you should be doing this in terms of the 1st of October appointment shift. I wonder if that's going to start coming through with a view for plans from January onwards to make look of the April contract shift turnover.
So that's the further management of potential variation in demand at GP practices and access at GP practices. So they have to develop a plan to address those. Shifting from sickness to prevention. So just highlight some sort of key areas that it appears the focus will be on. So to look out for, significant focus on obesity, a focus on reduction of cardiovascular disease, premature death and illness, implementing opt-out models of tobacco dependence in routine care. Can you decode that, Gandhi? Implementing opt-out models of tobacco dependence in routine care. It sounds like smoking cessation, a focus on that to me, but
which is interesting because they turfed a lot of that over to public health and then defunded it across most places. So recognition that still needs to happen. But I'm not quite sure what they're angling for.
It may land in the neighbourhoods, maybe. I don't know. Reducing exposure to antibiotics. So, antibiotic stewardship being a focus as well, and demonstrating how they will reduce health inequalities in the exercise of their functions. So, it's always worth, if you're out there listening to this, just making sure that that's not forgotten amidst all the other conversations that happen, and it's a key part of these documents. So you can remind ICBs and neighbourhoods of that if that's something that's a particular focus for your population. 2.4, doing digital differently. So just picking out a few things here. They continue to talk about this digital by default phrase, and talking about AI assistance at the front door in the NHS app, using technology to transform planned care, so putting patients in control of how they move through planned care pathways, and helping patients manage their own health by integrating functions to support that within the NHS app. They talk a little bit about how doing this will help the wider sort of economy through reduction in sick days and so forth as well. There are more targets for adoption of the NHS app and its utilisation in treatment as well. What else did I pick out? They want to get platforms on the NHS Federated Data Platform. I don't know if it's worth saying a few words about that, Gandhi. What that is, just to...
so this is about the way that we share information in a slightly more secure way, and the adoption of that throughout different trusts, so that hopefully information flows better. But also, it's using that concept of federated platforms so that it's still maintained within the organisations. It's a good idea, I think. It's how they're getting people on board is a bit more trickier. And interesting that they talk about some of the different ways of sharing information. The next one I thought was quite interesting was moved to all direct-to-patient communications to NHS Notify. So this is the notification system within the NHS app, and trying to reduce the reliance on SMSs in particular. So it moves to more push. Now, the easy answer to this is to just switch it on, make it an opt-out, not an opt-in. I mean, I don't understand why they don't want to do that. They're so focused on data governance side of things, but then when it comes to things that would actually make a difference, just make it an opt-in rather than, an opt-out rather than an opt-in on the NHS app. It's weird, but
lots of potential there though, and to replace postal letters as well, because there's still a lot of those flying around, and they're costly, and actually it's not a terribly reliable way of landing information with people. Addresses go out of date, people don't always open their mail and so forth. So yeah, but that's really, I think that's actually potentially quite powerful if they can pull that off. And actually, the more they move on there, the more that there's a critical mass of information in your NHS app, and you're more inclined to use it. The more stuff that is there, AI to support access and triage, as you would expect. I've just highlighted ambient voice technology should be adopted at pace. So I think that's just a strong signal for those people who are not moving in that direction. All of the key policy documents are talking a lot about ambient voice technology. So I think that's a steer to start to deliver
if people want a guide on that, we've got an episode that helps you do that, which we'll show at the end.
Yeah. So 2.5, transforming our approach to quality. I haven't highlighted a great deal in this section, really, but this talks about quality and governance frameworks. I think it's important to have a look in there, but I don't think we need to spend time there now, Gandhi. 2.6, understanding and improving the patient experience. Again, just mentioning to highlight that is a key part of the document. I've not picked out any specific statements there. There were some interesting ways to do that talked about in the 10-year plan, such as patient payments, for example, based on patients' interpretation of their service. I mean, it wasn't fleshed out, but payments based on patient experience, for example. 2.7, reconnecting with our workforce and renewing and strengthening leadership and management. Again, so that's their aspiration. We were both smiling a little bit, Gandhi, as we look at that aspiration. What was on your mind there?
No, just it's good to see a focus on the workforce, I think. Often find it tends to be one of the later ones, which is, I don't know, is that an indication or not? Again, cynicism may be coming through.
Yeah, it's tough, isn't it? So it's just a few things that they mention here. So they talk about calling out all forms of discrimination, and they talk about a focus on leadership. They talk about having a new management and leadership framework. They talk about developing a college of executive and clinical leadership, establishing that. They talk about new national leadership programs. So that might be an update to the sort of current NHS suite of leadership programs that are there, potentially updating, those, maybe making changes to content or how people access that. And then the last session talks about genomics and life sciences, which I won't go into in detail, but this has been an area that's been a surprisingly big part of the 10-year plan. And other documents, and even made it into sort of neighbourhood genomics is going to be a thing as well, which is interesting. So that was that section. Hopefully that's helpful. Can be a little bit thick to get through sort of contracting and organizational layers, but it is important ultimately. Gandhi, I think you'd had a look more closely at section 3. Oh, go on.
Yeah, so then this section 3, talks about trajectories for operational performance and transformation. I guess this talks more about the doing, and in particular what that looks like. So mindful of time, we're going to go through this at a little bit of pace, but effectively it talks about the different sections. So first up was elective cancer and diagnostics. In particular, it goes back to some of those principles of getting it right first time and trying to make sure that people are seen in an effective way. Again, those themes of digital first is very much there. In fact, if you go to the page 26, I think it is, Andy, on the top of the right hand, I think you're all there on it, top right corner. So the key priorities will be, and the first one it says, general practice is asked to continue prioritizing the use of advice and guidance prior to or instead of a planned referral. So very much a focus on using digital mechanisms to share information and things. And the next one is then again talking about advice and guidance, and we encourage systems to ensure all referrals repeat appropriate clinical triage, which then expect to flow to a single point of access. In particular, it looks at focusing on the 10 key areas that they want to see this focus on. Now, annoyingly, it doesn't mention what those 10 key areas are in this particular document. Again, commentary to Wes and Jim Mackey. You know, it'd be nice if you put some appendices with this to give a bit more explanation. So I'll be honest, in some ways, it's not a really well documented, written document. But so I had a look through and I did manage to find out what those 10 specialities are in some other documents. So it's gastroenterology, MSK, dermatology, ophthalmology, cardiology, urology, ENT, general surgery, general medicine or acute medicine, and gynecology. So they seem to be the 10 key areas that they're expecting to see a bigger drive through of advice and guidance going through in terms of particularly elective care. There's then a focus on waiting times for cancer diagnoses that it then talks about in the following pages. And basically, maybe we're just jumping to the table that's on 28, Andy, now, which is the summary of the key targets there that you can see. So improve the percentage of patients waiting no longer than 18 weeks for treatment. So minimum criteria that they've got there, and a standard they're expecting by the end of the 3 years, which 92% of patients are waiting for 18 weeks or less for their treatments when it comes to outpatient referrals and things. The second one is around cancer care. So constitutional standards, making sure that we reaffirm to those, maintaining performance against 28-day cancer faster diagnosis. Now, interestingly, there doesn't seem to be commentary about the whole concept of 2-week waits. And this is some commentary I've been seeing in other channels and stuff, that it seems to be we're moving away from this concept of 2-week wait as a structure and more 28-day diagnosis instead. And this allows some flexibility maybe for trust and other areas of providing these services. So, for example, I think some places they move towards 3 weeks for fast diagnosis for cancer, but potentially we're moving towards diagnosis should be made within 28 days, not that patients need to be seen within 2 weeks.
Yeah, maybe it's a superior, outcome.
Essentially.
It's not always gaming the numbers, but yeah.
Yeah, and there's some secondary criteria in there, into 94% performance by 31 days and 80% performance by 62 days by March 27, and that improves further later on. And then improved performance against DM01 diagnostic 6-week wait standard. So this, I'm not quite sure which this one meant, because again, there's no detail to explain this one. But yeah, further changes that come through. It then talks about urgent and emergency care. Now, we talked a little bit about this already, and just a reminder, and this was the one about the 90% that we talked about. So it doesn't state that this is general practice that needs to deliver 90% of urgent care. The headlines in the media and all the other kind of things absolutely have focused on that, it's general practice. It's not general practice it's asking to this. It's primary care, which it comes to in the second section, 3.3. But it does talk about urgent and emergency care, and this section is focusing more on things like 4-hour A&E times, which we talked about already, 12-hour A&E performances that definitely need to be improved, and the category wait times for ambulance service in terms of category 2. So this is like this isn't your heart attacks and your strokes. This is the next category down in terms of your ambulance wait times. So they are keen to see some improvements in that, and key actions on there. So stuff like working on flu uptakes. It talks about looking at utilizing neighbourhood services to provide some of these services. Some of that stuff that Andy's already mentioned in terms of the structure and the format that we see from there. So definitely some interesting stuff in there. 3.3 is when we go to primary care. We'll go through it. So continue on general practice. The first thing it says, 1st of October, contract change, make sure there's delivery of that. And the 2026-2027 GP contract from April. Now, there is no detail outlined what that looks like, but that says to me there is a clear signal there's something else coming from the government for 26-27. What do you think reading that, Andy?
Yeah, so it's interesting. GP contract from April, including improving and providing good access, whether by phone, online, or walk-in, throughout core hours. So that's modern general practice, isn't it? So continued focus on modern general practice. Okay. Fine.
And then it talks about additional plans to include contract oversight, commissioning and transformation, and unwarranted variation, again, coming up, and how to plan for that. And then ensuring capacity is commissioned to meet demand out of hours and over surge periods, including bank holidays and weekends. So, this is the ICB's focus, that they need to look at how they can help practice when there are surges. So winter demand, post-holiday, bank holidays, that kind of stuff. And then lastly, support primary care to provide ambient voice technology so that can improve time. So, key aspects of that. This is where the 90% has come in, as you can see in that table. So same day appointments for all clinically urgent patients, face-to-face phones or telephone, 90%. We will consult with the profession on this new ambition. So it's not set in stone. It's not the general practice. This is for primary care to deliver. So that includes your urgent treatment centres. That includes, other parts of primary care to support. And maybe this is, like you said, Andy, that move towards neighbourhood-based healthcare.
Yeah, I wonder if this becomes a responsibility of sort of neighbourhood potentially, but we don't know, and we'll have to watch that space. I'm noticing language alluding to increased like tighter contract management of general practice. I think that's something for GPs to be aware of and look out for, I think.
Yeah. And then the last part about the community aspects for this one is, in terms of primary care, is then to a much bigger focus on pharmacy related things. So embed pharmacy first approaches, enable HPV vaccines to be delivered at the pharmacies. Interesting there in terms of that one. Discharge medicine service to reduce the harm and complexity of patients' medications. Prescriptions being trackable in the NHS app, which is already starting to happen. That's really important to see. Using NHS Notify, being able to prescribing-based services as well. So various changes there. And then the last part on this section is about dental health services. So 700,000 more appointments by dentists being provided, and it's the ICB's responsibility to make sure this starts to be delivered. That's a key target they seem to be focusing on, and we know that dental access is a challenge currently for everyone. So it'll be interesting to see how that's delivered. 3.4 talks about community health services, and this addresses more the long wait times in community health services, so that reduces down to 78% being seen by 18 weeks and then 80% in the 28-29 targets. Like I said, I think this seems to direct more to things like your MSK treatment services and community respiratory health services in the community rather than the secondary care-based ones. And finally, for mental health, they've got the further metrics and stuff that come into play, both for strict mental health in terms of local mental health teams, coverage of health support teams, and in particular existing talking therapies access and that kind of thing, as well as trying to reduce and eliminate out-of-area placements for mental health emergencies. That seems to be a key metric. And then learning disability and autism, which is another section there. So reducing the need for mental health inpatient care for patients with learning disabilities and autistic patients, which is an absolutely sensible place to be, because a lot of these patients shouldn't really be inpatient mental health units and things. And then finally, it talks about workforce, which we had a quick look at before we started this one, didn't we? Well, I did. And yeah, it's, again, last section.
Quite small, right?
Yeah, quite small. Fully implement the 10-point plan to improve resident doctors' working lives. So interestingly, we're about to head into potentially another round of resident doctor strikes, but they've committed to making some changes, and particularly those 10-point changes, which was things like timings of shifts, various other aspects and stuff in terms of what goes ahead. Demonstrate reducing sickness absence, which is really poignant given the fact that one of the lead news stories yesterday was about 626,000 mental health days taken by NHS workers. So I wonder that's suitably timed. Continue to reduce agency staffing, which is we've seen as a key aim of the Labour government in particular. Statutory mandatory.
Yeah.
Sorry?
I would say eliminate it by August 2029. That's quite ambitious.
And then mandatory training framework for publication in March 26. So me and Andy had a quick look at this. I don't know if you're able to share that list, Andy, isn't it? But this is supposedly the minimum mandatory training requirements for people to be working from in the NHS. So, various different things. So those of you who are involved with CQC and stuff will recognise this quite clearly. But that's the minimum requirement now. I
think we'd sort of connected this with previous noise about making some of the training portable across different NHS organisations and potentially between NHS and social care to support the mobility of staff moving around the system.
Absolutely.
Which feels sensible if that's what it's alluding to.
And then finally, reforms to consultant job planning. Interestingly, nothing there around general practice again in terms of specific, apart from maybe that universal training framework may help some time. I know I've had some new starters, and the first week or so of them has basically been not them seeing patients because they've had to do their mandatory training because they can't see patients otherwise, which is a complete waste of everybody's time, given they probably just did it 4 months before. But we don't have the evidence, so therefore they have to do it again. Otherwise, we could get wrapped by CQC and things. But yes, and then finally, section 4, which is the planning.
Yeah, next step.
Sorry,
plan section. So people be relieved that this is not a long section. It's largely summarised in this table, sort of illustrating what comes next and who's responsible for what. And I think largely the responsibilities lie on sort of regions and ICBs who will need to come up with a plan to meet these development needs. First submission is around about October, so around about now, and then full plan submissions are around about January, February next year. First plan should be for 3 years, planning around workforce, finance, and performance, and then the full submission is for a 5-year plan on those things to update the numbers within the plan. So I'm sure those people who are working at ICB level and responsible for these plans will be have their eyes on those submission dates. And again, that's just talking about the contents within the plan. So first submission plan looking at use of capital, workforce, performance, activity, and so forth. 4th year plan providing more detail on those issues and adding operational performance and activity return there. Oh no, sorry, that's there in both. Really of interest if you are responsible for pulling together all or part of these plans for ICBs. So just know that that's what they'll be doing. So right, thoughts, reflections before we wrap up, Gandhi?
So I think it's a significant document to be aware of. We mentioned at the start that if you're involved in any form of ICB aspects and stuff, you definitely need to know about this document because this is the direction of travel for what you have to deliver over the next few years. I think for those involved in things like place-based partnership, PCNs, federations, larger practices, I think you need to be aware of this as well. This is going to direct some of the travel there. If you're involved in hospital commissioning, absolutely you need to be involved and have an awareness of this and what does this look like in terms of direction of travel. And even those in practice, I think, it's important to be aware of this is where some of the changes are going to come into play. There's taste, there's a taste there of what neighbourhood working might look like in the near future. It'd be interesting to see those model neighbourhood plans that come out potentially in the next couple of weeks or so, that we'll start to see more form and structure on there as well, won't we?
Yeah, so loose of documents that are coming out, as you say, sort of neighbourhood planning blueprints and so forth. So I think that those will be interesting to see. As ever, there's a real focus on digital. So digital, the NHS app, digital by default as a phrase that recurs. So people really need to be integrating digital as a key enabler in their plans and everything that they're doing. I think that that's really, really important. And I found sort of section 2 looking at the different levels of organisations within that kind of renewed system. And I'm really interested to know what they have planned for the small neighbourhood provider contracts, medium neighbourhood provider contracts, and the integrated care organisation layer of the system. So yeah, I think we'll watch this space.
Definitely. And if you want to understand how better to implement digital, particularly the AVT, then definitely check out this episode. Myself and Andy reviewed a structured guidance created by one of our friends, Devon, about how to do this from Wandsworth GP Federation. It's a great document and a great episode that shows you how to implement AVT in your particular area. And we may have more content coming here as well as we continue to tech enhance your primary care and learning. We'll catch you in the next episode.
Bye-bye.